Today we welcome Vincent Bourgonje, R&D Manager at the Eye Hospital Rotterdam. With over 100,000 ocular images analyzed, the Eye Hospital is driving impactful AI research at the intersection of ophthalmology and data science. Welcome, Vincent. Can you tell us more about your AI application with regards to glaucoma?
Yeah, of course, gladly. That's the project of Hans Lemay, one of our glaucoma specialists. And what we are trying to do is develop an AI-based glaucoma population screening. What do you know about glaucoma?
Myself, not very much, but I can imagine that the viewer also don't know a lot of glaucoma.
Well, what's important to know about glaucoma is that you get optic nerve damage. What happens first is that you lose vision in the periphery. Mm-hmm. So people don't notice it immediately because you can still read or watch television, that you do with central vision. So by the time people get complaints, much of the damage is already done. Mm-hmm. So you would be helped if you can screen for glaucoma early, then you can treat before much of the damage is done. And to do that, you need to do two things. You need to make a photo of the back of the eye, a fundus photo, and that's easy. Patient just sits down, flash, picture done. But then you have to analyze the picture, and that's very difficult. Only a glaucoma specialist can really do that and say, this is glaucoma, this is not. But if we, and that's what we've been doing, develop an AI tool that can say, hey, this patient needs to go to the glaucoma specialist and this one not, then it would be possible to screen really early. Mm-hmm. So for example, by an optometrist or even a general practitioner. They can make the picture, then the AI tool says, go to the glaucoma specialist or you don't have to go. That's the idea.
Oh, nice.
Yeah.
So as an eye hospital, you're using a lot of visuals, more than 100,000 visuals. How do you actually treat bias? How do you handle that?
Yeah, that's a good point. So in this case, the AI tool for glaucoma was trained on more than 100,000 pictures. That was the training set. Mm-hmm. But indeed, for example, if a glaucoma screening is tested on or trained on Chinese eyes, mm-hmm. then it will not perform well in Europe, for example, or the other way around. And yeah, the answer is you have to validate it. So you test it on one, or you train it on one set, and then you have to test it on another set. Yeah. That also has to include ungradable images, mm-hmm. So to make sure it's not confabulating something. And in our case, for example, we are now validating it in images from the Rotterdam study. So that are really people living in Rotterdam, mm-hmm. who are followed over the years, mm-hmm. and they also take fundus photos. So then you can validate your AI model on the eyes of actual people from Rotterdam.
Yeah, different groups of people.
Exactly, exactly. And then you can say if it really works. And at the moment we have like 74% sensitivity at 95% specificity. So that's good, but we can still do better, I guess.
And in terms of privacy and things like that, do you anonymize the visuals, or how does it work?
Yeah, the visuals have to be anonymized, indeed. Mm-hmm. And well, the good thing about a fundus photo is that I'm not going to recognize you based on your fundus photo, so that helps already. So, but there should not be any metadata on it, of course. The easiest thing, of course, is if the people who are providing the photo, so the patients, are already in agreement with that, if they already have given consent for using their data. Mm-hmm. And then, of course, the data needs to be anonymous,
Okay, very interesting. Nice insight. So what I can imagine is that people who are watching this, what can they actually learn from you? Maybe they're working at a smaller hospital. Mm-hmm. What can they learn from your AI approach?
Okay, I think the important thing is collaboration. Mm-hmm. So don't do it alone. So for example, with this glaucoma project, we actually we got that data set from another study. Yeah. And we added the labels to it, glaucoma or not glaucoma. That's a hell of a job. And then they set up a grand challenge so that different groups could, based on the test set, develop their AI tool. Yeah. And then in a competition, see which one works best. So that's a way how you can collaborate and get a nice AI tool. We're also working with the Erasmus MC, so we have the IR imaging group, which includes a few engineers, because we mostly have medical personnel, of course, at the Rotterdam Eye Hospital. And that group is co-funded by the Eye Hospital and by the Erasmus. And in that way, you both benefit from the technical knowledge. And of course, the engineers have data from 2 hospitals. So,
Okay.
Yeah, I would say that would be the way to go.
So working closely together with
Yes.
other hospitals and sharing data
Yeah.
in order to achieve more volumes of data sets so you can make better analysis is the key factor in being successful in the end. At least one of the key.
One of the key factors would be the proper way to say it. Yes,
Yeah.
I think so.
Yeah. You also have this beautiful project when it comes to AI in corneal transplants. Can you tell us more about that?
Yes, so yeah, that's also a very nice tool indeed. So that's developed by our cornea team. Jeroen van Rooij is the lead in that. With cornea transplants, you always have to check the endothelial cells. So the cornea consists of many layers, and the endothelial cells are the back layer. And one thing you need to know is that if the number of cells gets too low, you get corneal problems. So that's why you always need to check that. Making the pictures of those cells is easy again. So you just hit backflash, you got your image, you do that with a so-called specular microscope. But then somebody needs to count those cells. And we trained an AI tool, an AI model, to reliably count those cells. They segmented the borders of the cell, and then because you know the magnification, you can say there are so many cells per square millimeter. And advantage is that it's quick and that it is reliable. We're now using it for R&D. We're also sharing it with other R&D departments so that we can also validate it on their photos. So actually, we're not asking for their data because then you get that legal problem and all that stuff. We're giving them our tool so that they can test it on their own data. It's nice for them, they can do counts, and we get feedback back how good it works also on other image sets.
Okay, so very interesting. But also what I can imagine is that the daily work of doctors or maybe optometrists changes a lot. What is the impact of this AI application in terms of visual recognition?
Yeah, so we're now only using it for R&D, but we love to use it in the clinic in time as well. So we have also optometrists, and they now have 2 subpar options because they make the picture, and then you can make a choice. You can either let the software on the specular microscope analyze the image, but that's not very smart software. It makes a lot of mistakes. Sometimes it says, I cannot analyze anything, even though you can clearly see cells. Or you can do it manually, count those cells manually. But that takes a lot of time. So in the clinic, they never do that. It's too much time. But then you're stuck with the software. So if you could use the AI tool, it would be almost as quick as doing it by the device, but it's much more reliable. So yeah, we would love to use it in that way.
Interesting. So how much time do you actually save from doing it manually into the current situation? Can you make a comparison? Yeah.
So in R&D we often do it manually because the reliability is more important than the time, and it takes me 15 minutes per patient. With that AI tool, I can do it in 10 seconds.
Wow, so that's huge.
Yeah, and it's even better because with the tool I can also do my whole data set in one go. We also developed an interface that you can upload it. So then I can have a cup of coffee and let the cells run. In the clinic, time saved is less because they do it on the software of the device. But there we hope that the reliability is increased. And that's also a gain because otherwise an ophthalmologist, for example, might have to go back and check the raw data. But what you really want to have is that the numbers are reliable. So the gain there is more reliability.
Yeah, I can imagine. And also what we just also talked about is the team data integration. You have to work closely together with other health hospitals, other practitioners. What challenges did you find in integrating data or integrating all these visuals within other processes of other hospitals?
You mean when other hospitals share their data with us, or when we share data with them?
Maybe both ways.
Both ways, yeah. it's always a bit of a legal issue, of course. The best way is if you have consent from the patients. So the nicest thing is even if you can do it prospectively, that will be even better. Because if you have consent of the patient and your privacy officer says, yes, these data are truly anonymous, then much of your problems are gone.
Okay.
So that would be the best.
Vincent, how do you actually ensure that the AI is also fed with data from sources other than just the hospital?
Again, that's a matter of collaboration. So, for example, in the glaucoma screening, the fundus photos originally were actually from diabetic retinopathy, but you can also use it for the way we used it for glaucoma. But yeah, the doctors need to know each other, the researchers need to know each other to even know that that data is available. The same with the Erasmus, because we have that collaboration. Data is also more easily shared. So that will be my answer.
Yeah, okay. So collaboration, working together and integrating the systems and processes is very important in this case. And if you're looking at also making internal teams enthusiastic about using AI, I mean, you have to deal with medical staff, you have to deal with IT department, maybe with data teams. How do you actually, what are the main pitfalls when in order to make them enthusiastic about this AI application?
So that's always, so the R&D department is always enthusiastic, of course, but they love doing R&D. But in the clinic, the main problem I run against is, the care has to go on. So that's always the primary duty. So what you really need is, preferably, you need their buy-in. You need to have them enthusiastic. So for example, if a startup would approach us with a good idea, we always set up also a session with the doctors that could potentially benefit from that. Because if they are not enthusiastic, if they do not see the benefit, then it's not going to happen because they have to do the work additionally to what they're already doing. So get that buy-in early, I would say. And then it can work because they do see that it can, for example, save time. All ophthalmologists are interested in saving time.
I can imagine, And do you work with, for example, with storytelling? How do you put this into practice? Or do you work with just small experiments? How do you get these people?
Yeah, that's a good point. So the glaucoma screening and the cornea, that was actually initiated from those departments. They saw the opportunity and then they said, well, we need to know how. So that's easy because then they initiated it. The other way around, if it's with a startup, before we even start, we invite the relevant group. And then I tell that startup, you go and convince those doctors that you can help them. And then start small. So if they can see a benefit early, that's the way to go, I think. So in order to really have them with you, in some cases the initiative comes from them, and in other cases the initiative comes from the R&D department. What is, in your opinion, basically the biggest misconception when it comes to AI, using AI in healthcare? It's a bit of a broad question, of course, but in my experience, do not fear, do not hype. So it's nothing to be afraid of, but it's also nothing to be over-enthusiastic of. AI is a tool. So and if it can be used, if it improves care, you will notice it quickly. I also get the idea, based on what I see now, that AI is there to support, but it's not going to make the decisions. So for example, save time. And to ophthalmologists or doctors, I would say, in the end, they get a say in that, a very big say. If they are not impressed by the tool, then it's not going to be used. So that's actually a main reason not to fear, not to hype, because you decide whether it's useful and it gets used.
And do you recommend other hospitals or maybe even healthcare organizations to build this AI application themselves, to purchase it or to make a combination of it? What do you recommend?
I can only look from our experience, and I think we can still learn a lot as well. But that grant challenge, that was great, of course. So you have the data and you put in the medical information on that, the labels, glaucoma, yes, no. But you don't actually build the AI yourself. Or you can, like we did with the collaboration with Erasmus, if in that way engineers associated with your hospital. And then it is possible that they can make the AI. Those are the two ways that we've been doing it so far.
Okay. Yeah.
And that seems to work for now. Yeah.
Yeah. And when it comes to the future, what is in your opinion? How does the future look like when it comes to data and AI in healthcare?
Well, there's one thing, and I'm guessing other hospitals see that as well, that where we really think AI would be a good additional use, and that's in summarizing the data for the doctor. So now an ophthalmologist, when he starts his consultation, he has to look at notes, he has to look at patient file, he has to look at a whole bunch of images and scans taken from different devices over different years just to get disease progression. And then half of the consultation time is gone. If you can train an AI to predict what the doctor needs to see or wants to see, that would be great.
Yeah.
That would be amazing.
Yeah, that would be amazing. So if you would describe the time a doctor uses now for consultation versus the doctor needs in the future, how much time is he going to save?
I think he's going to save 50% of its time.
Wow, that's huge.
Yeah. And it's also nice for the patient, of course, because it means there's more time for the patient and there's more time for the doctor to actually listen to the patient instead of looking at data on his computer.
Yeah.
But we're not there yet in our case, maybe somebody else.
Yeah, I mean, at least you started with AI. It's now in a phase that you have some successful examples. Can you also describe maybe some obstacles that you have faced during the implementation of both applications?
Yes. So to get it from R&D to clinic, that can be difficult. So, for example, the endothelial cells, that AI tool, does not have CE mark. Is not CE marked yet, for example. So we cannot use it in the clinic, even if we already know in R&D it works better. But then we need money and time. And I don't think we can. I mean, it's great for us, but there's not a company that's going to make money out of it. So that can be a difficult step. But we'll get there. I'm pretty confident.
Yeah. Thank you. Thank you for this very interesting insights, Vincent. I think they were very helpful. And thank you for being part of this talk show.
Yeah, my pleasure.
And
thank you.
Hope to see you next time.
Okay.
Want to learn more about this topic? Download this white paper from Digiteum. You can find the link in the comments. Digiteum has established itself as a trusted partner in the healthcare sector and beyond, serving as the official technology partner of Diaceutics, Sanofi and Oxford University Press.